so this is the third most common cause of readmission, periprosthetic fracture. The important point is it can increase the chances of post-operative. There are increased incidences of PJI after the periprosthetic fracture. We all know the use of uncemented implants, osteoporosis in females, and especially in the revision scenario when there is a presence of cement, sclerosis, number of previous surgeries in the same regions. These are the common causes of periprosthetic fracture. The Vancouver classification gives us site of the fracture, the stability of the femoral component, and quality of remaining bone stock. These three factors will decide the management, what we are going to do. On basis of this, these are the classification A, B, C. I don't want to go into the details of this, what are the classification, but the aim is to restore the alignment with stable implant. If the implant is loose, you should make it stable. Maintain the bone stock if it's not adequate. Fracture union has to be there because this is a fracture. Early mobilization and promote the joint motion. So these are the aims of the treatment, whatever you do. And as he rightly said, you need both trauma, advanced trauma and arthroplasty skill. Both you need to do this. I just want to go into the clinical scenario only. B1 fracture, tip of the stem, right? Stable implant. This has been done, nicely done, right? And good fixation has been done. The problem here is medial combination. Somebody was asking about cortical strut. This is the case where you need to put fibula graft or a second plate or a bone graft. This is going to fail, right? So this is the lesson. Another case, stable implant, good bone quality, adequate bone, fixed like this, still not following the principles of trauma. This is not a biological fixation. The screw is through the fracture site and it has failed, right? No bone grafting. Third case, and this is the case which failed. Now we have done proper bone grafting, distal femur plate, biological principles, relative stability, it united. Another case, failed second time, no bone support on the medial side. This is the case where you need fibular strut graft and ultimately it united with that. So you have to be, the message is that in this sort of cases, you must put a bone graft when there is a medial combination or put a second plate. And your long span of the femur plate, no screw clusters, and maintain the plate span width. These are the principles of the trauma. Another scenario. Now, the stable implant, no, it is not stable, but the good bone stock is there. Here we have to revise this. So it has been revised, and your distal stem has to be 2 cortical diameter distal to the fracture. So this is how it has been done with multiple K wires. Again, a mono block stem has been used. Second case, adequate bone stock, but the implant is stable. Here it has been fixed. Now this has been fixed very well because they have used bicortical screws or screws in the proximal part. Only tension band wire, circlage wire in the proximal part is not a good idea to do. So this is the third case where you can see very nicely done interfragmentary screw, no screw in between, and it is united well because there are screws above and below with a long span. So this is the message and the principle we have to follow, that if you only put circlage wire, this is the case somebody has done. This is not the right thing. We know this is going to fail. So this is not the case. We have to learn long span and put screws in proximal part also. Another scenario. This is cemented prosthesis done. Patient had a fall. Now this has sunk. This has sunk in, so the implant is loose. Here we have to change the implant. We cannot only fix. Remove the cement and put a long stem prosthesis, and this has been done. So another case, there is a lateral or a wall fracture. This is a loose implant, but no adequate bone stock. So when you don't have adequate bone stock, you supplement with fixation. Again, long stem with supplementary fixation with a revision stem. Another case, here is a cemented, somebody has done, and it is fractured like this. They have put a long cemented stem, but it has been supplemented, sorry. Okay, it's gone, okay. There are another cases where there are no adequate bone, where you have to supplement in the revision B3 with the fixation also. As mentioned again, these are the cases you have changed and put a long stem monoblock non-modular stem. A similar cases here, and as everybody has said, in B2 and B3, the workhorse is this Wagner or monomode like non-modular fluted tapered titanium stem is the case where maximum things can be done with this particular thing. Here another case where B3 inadequate bone stock, right, and this treatment option is going to be the proximal femoral replacement. So another scenario, you have a THR and TKR below interprosthetic fracture, and in this case is again when you fix it, keep in mind there is no stress riser and adequate fixation has been done, otherwise the patient will get fracture in between. Follow the principles of trauma, overlap the prosthesis, span the whole femur. So these are the principles. Another case here, in between the fractures, you have to span the whole femur. This is type C. Of course, TKR is there, but away from the THR. So this is a fracture where again you have to fix it on the principles of the trauma, long span, and you have to cover adequately. So another type C fracture where the femur fracture is below and it should be covered with a long span of fixation. So message here is that in Vancouver C, they protect the whole diaphysis, otherwise you will get the fracture above. And the locking plate with the maximum fixation and at the distal metaphysis and combination of screw and cables proximally, that is most important. If you can put bicortical screws above, even if the femur stem is there, that is going to be the most important thing for you. A clinical scenario where you get the fracture while putting the prosthesis intraoperative, we all know that you can see that lesser trochanter, if it's stable, you can put the tension band wire, but make sure that you expose properly, because you think this is a small fracture and it will be done with a small plate or a tension band wire, and when you take a post-operative X-ray next day, you see like this. So this should not happen. Expose properly, make sure that the fracture line is not going below intraoperative fractures. Though they look stable on to you, just make sure and adequate exposure is to be. There are some newer things which has come. So this is the thing which is known as far cortical locking screw. You can see these are the different type of screws which gives a better fixation, and we all know about variable angle. Now variable angle screws gives you some possibility of putting a screw, even the stem is there, and you can put a variable angle screws, and these are the newer innovations, the far cortical locking screws and variable angle screws. The message is biomechanical challenges are there because of the femur. During fixation, follow the principles of relative stability or the locking plates. Whenever required, put a bone graft. Use bicortical screw whenever is possible. Don't rely only on the cables. And when the prosthesis stability is compromised, when there is inadequate bone stock, you must use a revision stem like the Wagner or a monomode. And sometimes you have to additionally do the fixation along with the revision stem. Thank you.